thank you for joining us for this media briefing, which is coming to you from the Africa Centers for Disease Control and Prevention. We bring it to you every Thursday with the aim of updating the continent and the world at large on the pandemics that might be affecting the continent, advice on response and preventive measures wherever possible, as well as general information on the response effort by the African Union through the Africa CDC, which is its technical agency. So my name is Wayne Musabayana, and I will be your moderator for today. I see that some colleagues are still joining us, but I think that we can start and hand over to the Acting Director of the Africa CDC, Dr. Ahmed Ogwell, for his briefing for today. Dr. Ogwell, you have the floor.
Thank you. Thank you very much, Wayne, for the introduction, and good morning, good afternoon, good evening, colleagues, wherever you're joining from. Today, I would like to start with the COVID-19 overview before we go to other outbreaks here on the continent. So as of today, the 6th of October, 2022, the following is a report from all our 55 member states of the Africa Union. That to date, we have documented a total of just over 12 million COVID-19 cases that have been reported on the continent. And these accounts for 2% of the total cases reported globally. We have seen just over 11.4 million recoveries out of the 12 million that were affected. And this is 95% of those who are reported to have COVID here on the continent. Unfortunately, we have documented over 255,000 deaths, and this gives us a case fatality rate for Africa of 2.1%, which accounts for 4.1% of the total number of deaths reported globally due to COVID-19. Our case fatality rate, the 2.1%, is actually higher than the global average of 1.1%. And as of this week, 41 of our countries are reporting a case fatality rate that is higher than the global average. 2 countries, Somalia and Sudan, are still reporting a case fatality rate that is higher than 5%. When we look at the analysis of the past week, and that is epidemiological week 39, which ran from 26th of September to the 2nd of October. And we compare it with AP week 38. We see that a total of 5,106 new cases were reported in Africa, which gives us a 14% increase. That is 14% increase from the previous week. The highest proportions we see are from the Southern Africa region, with 39% of the new cases being reported. The Eastern Africa region accounts for 25% of these cases, Western 16%, and the Central and Northern regions each with 10% of the new cases. The top 5 countries reporting the highest number of cases during this week are South Africa with 1,525, Seychelles with 783, Tunisia with 341, Ghana with 285, and Cameroon with 254. During this AP week 39, a total of 53, that is 53 new deaths were reported here in Africa. This is a 33% increase from the previous week. When we look at the 4-week trend analysis, it shows that the number of new cases during the last 4 weeks compared to the previous 4 weeks has increased by 1%. And these this 1% increase affects the regions very differently, where some have gone up when others have gone down. And the regions most affected by the increase are Eastern and Central Africa regions during this period, with Eastern documenting over 2,000% increase and Central over 800% increase, while the other regions were showing significant decreases. During this 4-week analysis, there has been an overall 7% average increase in the number of new deaths that were reported on the continent. And the regions that have been most affected by the increase are Southern, with 59% increase, Western, 38%, and Eastern, with 16% increase. The situation of COVID-19 vaccination on the continent as of the 3rd of October 2022 is as follows. We have received 980 million COVID-19 vaccination doses, and these have been supplied across all our member states, 54 of our member states. And the number of doses that have been administered is 713, which corresponds to 73% consumption rate of the supplies available here in Africa. Coverage is now standing at 22.9% of the total population being fully vaccinated, and 2.8% coverage for booster doses. When we look at vaccination trends, in the past 4 weeks, and that is the period between the 6th of September to the 2nd of October, there has been an increase from 22.2% to 22.9% for those who are fully vaccinated. Percentages like this may look small, but in reality, it is almost 10 million new doses that we have delivered to people's arms over this 4-week period. So although the increase is looking small from 22.2% to 22.9%, it represents 10 million doses that have been administered. When we look at EPI Week 39, we see that some countries have made significant increases in the vaccination rates. Those that have increased by over 25% include Burundi, the Central African Republic, Chad, the DRC, Cameroon, Comoros, Djibouti, Madagascar, Tanzania, Libya, Malawi, Mozambique, South Africa, and Mali. These countries have seen their rates increase by at least 25% compared to the rate they had in the month before. Contributing factors to this decent increase in the population coverage for vaccination of COVID-19 include our Saving Lives and Livelihoods door-to-door campaign, which has been implemented in some countries, including Tanzania, the increased efforts to engage with the community with the correct messages, as we are doing in the DRC, and mass campaigns in the lower age groups between 12 and 17 years, as we are doing in Mozambique. This represents a significant change in the rate and pace at which we are seeing vaccinations happening here on the continent of Africa. We therefore recommend to our member states that we need continued advocacy from our political leaders and influencers so that the public can be able to take up vaccination even faster. We are also encouraging tailored risk communication and community engagement activities in each and every country, in each and every part of the countries. We also need to improve the way in which we are managing our data so that the results of vaccination becomes available faster than they are right now. We also need to ensure that we are expanding the door-to-door campaign, the mass vaccination in places where the members of the public are congregating, and we need to specifically target the youth as we are doing through our Bingwa initiative. When we look at the SLL implementation, we see that in the coming weeks, implementation is going to begin in 4 additional countries, and that is Uganda, Comoros, Djibouti, and Malawi. And this will join the countries that are already implementing mass vaccination campaigns, which include Ethiopia, Kenya, Nigeria, Rwanda, Namibia, and Lesotho. And of course, Zambia and the DRC and Tanzania joined only last week. So the number of countries that are implementing the Saving Lives and Livelihoods initiative is growing, and we are seeing from the data we are gathering from the ground that in all these countries, vaccination rates are also going up. Let's now move to the other public health threats that we are seeing on the continent. And first is the good news that from Tanzania, the cholera outbreak that we had there is now officially closed as a public health event because the active transmission has been successfully brought under control. The ongoing outbreaks that we are dealing with on the continent, apart from COVID-19, are 11 in number. And today we will discuss only 4 of them, as they are significantly more serious than the others. Of the 4 that we're going to discuss today is Ebola in Uganda, monkeypox in multiple countries, Rift Valley fever in Mauritania, and cholera that is also in multiple countries. But do bear in mind that there is still flooding in the Sudan, which is causing a lot of public health risks. There's still influenza, H1N1 in Namibia. Lassa fever is still there in multiple countries across the continent. Measles is still there in multiple countries across the continent as well. Yellow fever in Cameroon, hepatitis E in South Sudan, and Crimean Congo hemorrhagic fever in Uganda. We will not discuss those ones in detail, but it is to provide you with information that indeed there are quite a number of other public health events that are significant and are continuing around the continent. So we will start with Ebola. And since the last briefing that we had a week ago, 19 new confirmed cases and 15 new deaths due to Ebola virus disease have been reported from 5 districts in Uganda. And this is a 20% decrease in the number of new confirmed cases compared to the last briefing. Cumulatively, 43 confirmed cases with 30 deaths, giving us a 69.8% case fatality rate, have been reported from the 5 districts. And of the total number of cases, 15%, and that is 10 in number, are actually health workers. And we have unfortunately lost 4 health workers during this current outbreak. The good news is that we now have 7 recoveries from this outbreak who have now been reintegrated back into their communities. In addition to this number of confirmed probable cases and those that have passed away, we have 867 active contacts that have been listed, and at least 78% of them are currently being monitored. This is a very important step because compared to the last briefing, we are now seeing a situation where monitoring has almost doubled compared to last time when we were monitoring just around 48 or so %. So of the contacts that have been listed, 78% are being actively monitored during the period for incubation to ensure that they do not carry the virus and are integrated back into the community. So the Ministry of Health in Uganda continues to ensure that members of the public are provided with the right information. Governance mechanisms have been put in place, including district task forces that meet regularly to engage with members of the public. A response plan has been prepared. Partners have been mobilized to support the country. And indeed, new emergency treatment units have been established in different parts of the 5 districts that are affected. We are supporting, as Africa CDC, supporting the Ministry of Health in providing all this very important engagement with the communities. And we are also working with the ministry to provide more test kits, train more laboratory scientists, open up more platforms for testing so that we can have shorter turnaround times in the affected areas. Next week, on the 12th of October, Africa CDC, in partnership with the World Health Organization, our Regional Office for Africa, and hosted by the government of Uganda, we are holding a high-level ministerial emergency meeting to discuss cross-border preparedness and response for fast-moving outbreaks like the Ebola that we are seeing in the country. All the neighbors of Uganda, that's the DRC, South Sudan, Kenya, Rwanda, and Tanzania, have been at ministerial level have been invited to this meeting next week on Wednesday. And indeed, for purposes of sharing experiences, we've also invited Sierra Leone, Liberia, and Guinea at ministerial level to participate in this one-day meeting so that we can have alignment within the region for cross-border activities. Some of the challenges that we are facing still is that this is the Sudan strain of Ebola the virus, and therefore we don't have rapid test kits yet, and we also do not have a vaccine that has achieved emergency use authorization, and therefore we cannot use that particular tool in our response mechanisms. We are therefore very busy supporting infection prevention and control measures. We are providing support for the isolation of cases that are suspected or confirmed. We are providing support to ensure that members of the public are being given the right information across the country. Indeed, we are providing support to all the 5 neighbors to ensure that their systems, not only at the border lines, but even internally within the country, have a higher index of suspicion so that they are more prepared than before. The second is monkeypox, the multi-country monkeypox outbreak that sees its footprints outside of the African continent. Since the last brief that we had on the continent of Africa, 8 new confirmed cases and 238 suspected cases with 17 new deaths as a result of monkeypox have been documented. And this gives us a case fatality rate of 6.9%. The countries reporting these new cases and new deaths include the DRC, Ghana, and Liberia. This represents a 3% decrease in the number of new cases of monkeypox that we are seeing on the continent, with the DRC reporting 238 suspected cases. And also we have documented 17 new deaths in the DRC, giving us a case fatality rate of 7.1%. In Ghana, 7 confirmed cases, no new deaths. In Liberia, 1 confirmed case, again, no new deaths. Cumulatively, from the beginning of the year, we have documented 5,813 cases, including 703 that have been confirmed, while 5,110 are suspected. 155 deaths, giving us a 2.6% case fatality rate across 12 of our member states here in Africa. As Africa CDC, we continue to work with the affected member states, particularly in strengthening surveillance and care of those who are affected. Unfortunately, to date, we have not yet secured any doses of vaccines, but we continue to work with and negotiate with those who have these vaccines. The third public health event which is significant is Rift Valley fever in Mauritania. Since the last brief, 8 new confirmed cases and 35 suspected cases, with 5 new deaths have been reported in Mauritania, giving a case fatality rate of 15% for Rift Valley fever. This is a 19% increase in the number of new cases compared to the last briefing. Cumulatively, from the beginning of this particular outbreak in Mauritania, we have seen 32 confirmed cases, 113 suspected cases, 17 deaths, giving us a case fatality rate of 12% across Mauritania as a country. The Ministry of Health there has enhanced their surveillance mechanisms. They are doing active contact tracing and community sensitization in the areas that have been affected. As Africa CDC, we continue to provide them with the technical support as they need it. The fourth and last one that we will discuss today is a multi-country cholera outbreak. Since the last briefing, 462 new confirmed cases and 3,023 suspected cases, with 78 new deaths have been reported, giving us a case fatality rate of 2.6%. And these have been reported from Cameroon, Malawi, Nigeria, and Somalia. These numbers represent a 9.6% decrease in the number of new confirmed cases. Cameroon has reported 56 cases confirmed, while 210 are suspected. Also, 7 new deaths in Cameroon, giving us a case fatality rate of 1.5%. Malawi has reported 405 new confirmed cases and 8 deaths, giving us a case fatality rate of 1.9% in Malawi. Nigeria, with 1,841 new suspected cases and 58 new deaths, gives us a case fatality rate of 3.2%, while Somalia has reported 511 new cases, including 1 confirmed, 510 suspected, and 5 new deaths, giving us just about 1% case fatality rate. Cumulatively, from the beginning of this year, we have documented for cholera 45,321 cases, including 6,310 that are confirmed and 39,011 that are suspected, with 726 deaths, giving us a cumulative case fatality rate of 1.6% across 14 member states of the African Union. We continue to work with all the countries that have been affected by this particular outbreak. Now to other announcements that have occurred over the last 2 weeks or so. You will recall that we were in the UN General Assembly 2 weeks ago, and during that time, we held 3 very successful events. The update today is that 2 documents have now been released on our website. That is the call to action on the new public health order by our heads of state and government, and a communique on reimagining health workforce development for Africa's security, again by our heads of state and government. Essentially, these two side events were for our heads of states to call upon our own governments, multilateral institutions, philanthropies in the private sector, including civil society, to support the full implementation of the new public health order so as to ensure that our health security here on the continent is part of the global health security architecture. So these two documents are now available on our website for your consideration. During the UNGA week as well, we signed 2 MOUs. The first one was with Smart Africa. And with Smart Africa, we are going to strengthen and expand digitization of Africa CDC's work. Our ambition is that during outbreaks, we are able to receive the information as quickly as possible. And we want to digitize the way in which information is transmitted from the community to the national level and eventually to Africa CDC. This will improve our response time and ensure that we can be able to arrest any outbreak before it becomes a community problem. So that was the MOU we've signed with Smart Africa. The second MOU we signed was with Path International. And this one is to expand the work we are doing with them on health security, particularly capacity building, particularly for local manufacturing of health products. And with Path, we have started implementation of this particular MOU. During the UN General Assembly, I also had the honor of speaking at the COVID-19 Global Action Plan Forum of Foreign Affairs Ministers from across the world, where I shared with them our lessons learned during Ebola, during COVID, during monkeypox outbreaks and other similar outbreaks. And I urged them to realize that, for us, the pandemic is still very real on the continent because of low vaccination rates. And I also emphasized that regional institutions like Africa CDC are really the key to successful interventions, not just here on the continent of Africa, but elsewhere as well. So these regional institutions must be part of the global health security agenda. This past week, I also welcomed the CEO of Gavi, Seth Beckley, and we were discussing here how do we strengthen our existing cooperation, particularly in vaccine delivery and also in vaccine administration to the public. We've also agreed on a way forward on local manufacturing and making sure that there is a market for all the health products, particularly vaccines that are going to be manufactured here on the continent of Africa. Last week, on the 29th of September, Her Honor, the Vice President of the Republic of Zambia, launched the Africa Continental Framework on Mortality Surveillance. And we had the honor of hosting her in Lusaka. And this particular document is a consensus. It's a consensus technical guidance document, which will be the tool that our member states here in Africa will be using to improve data collection and sharing on causes of death in each and every country. When we know what is causing death in each and every country, then we are able to plan and respond faster and more precisely because we have that information. So that particular document, the framework, has been launched and now is going to be used by the countries on the continent. Wayne, I think this is what we had for today, and we are happy to receive any questions from the journalists, but allow me to repeat that on the 12th of October next week, we are in Entebbe in Uganda for that high-level ministerial emergency meeting on cross-border surveillance, preparedness, and response to not just Ebola, but any other fast-moving outbreak. Thank you.
Thank you very much, Ahmed. And it's a very good point for us to segue, perhaps to introduce Dr. Merawi, who is the head of emergency preparedness and response at the Africa CDC. We're going to give him just about 2 minutes in case there is any additional information that he has with regards to that Ebola outbreak. But while he's giving us his 2 minutes, I just want to give out the WhatsApp number for your questions. It remains +251 945502 310. We also welcome questions on Zoom, either live or through the question and answer section. For now, let me just say good morning to Dr. Merawi, and you have your 2 minutes just for updates on the Ebola outbreak.
Thank you, Madam. Good afternoon, colleagues. It has been said very well, and I just want to give some brief Africa CDC plan for the next 1 or 2 weeks' time that we are going to support the government of Uganda and all other neighboring countries in the region, in addition to the high-level ministerial meeting. This next week, we will start to give surveillance and contact tracing training to all affected districts in Uganda and support alert management system setup in that country, because a number of alert reports are coming from members of the community that need to be really well managed. And we also give risk communication community engagement training and plan to have regional laboratory specialists with RT-PCR technique diagnostic testing training to be given for the whole of the region. And DRC, Institute of National Biomedical Research Institute in Democratic Republic of Congo. And we are expecting our cargo of test kits to arrive early next week to support the neighboring countries as well as Uganda. And we have a continuous engagement with the regions. We are currently identified major gaps and challenges in a number of member states that need to be filled. We are currently closely working with our partners to support those countries. I think one good point that I just want to flag in here is yesterday around 139 contacts have been graduated from follow-up because they have already finished from the day of. This is a really good news that the government of Uganda is accomplishing the past one day. Thank you very much.
Thank you very much for that update, Dr. Merawi. Now we have come to the question and answer section, and the first question that we have today is coming from Judith Akolo, who is working with the Kenya Broadcasting Corporation. And she says to Dr. Ogwell, considering the drop in COVID-19 infections in Kenya and the rise in the numbers of infections in neighboring Somalia, should Kenya be worried about this state of affairs? And what must the government of Kenya do to ensure that the successes that have been registered in dealing with COVID-19 are not rolled back on account of the rise in infections in Somalia?
No, thank you, Judith, for that question. COVID anywhere is a risk everywhere. So long as numbers are still rising in any part of the world, and particularly neighboring countries, of course, the risk is still there. What each country needs to do, there are three major things. One is surveillance. We need to have our surveillance systems to be awake and functioning 24/7 across each and every country, particularly at border points. In this way, any case is detected rapidly, and then the response is instituted. This is the first thing, surveillance. The second is we must have within each and every country the capacity for managing a case of whether it is COVID or any other disease. That capacity to manage a case safely must be in place. So isolation centers, quarantine centers, well-trained staff with the right tools to do the work, good medication, therapeutics. Very important that we have the system in place to manage a case that may require to be managed within a facility. The third very important thing is vaccination. We know the tool works, and therefore we need to head towards the 70%, which is the target. And my advice to all our member states is when the transmission is low, this is the time for us to increase our rates of vaccination so that if at all any other wave comes, it finds most of the population to be well protected and we end up with few, if any, serious illness situations. So any case of COVID, Judith, anywhere is a risk. We need to prepare within each and every country so that any case that comes, we can pick it up quickly. And if necessary, we then manage that case in a safe way to avoid further transmission into the community. Thank you.
Thank you very much, Ahmed. We have Paul Adepoju who has his hand up. Paul, please go ahead with your question. Hello, Paul. All right, perhaps let me proceed with another question that's coming in from Judith. And Judith says, yesterday, meaning Wednesday, the Minister of Health for Uganda announced the death of another medic in Fort Portal in Uganda. Could this be a sign that the Ebola outbreak in Uganda could get out of hand?
Thank you, Judith. And I will also ask Merawi to give us a little bit of detail around the issue with the health workers in Uganda. Two things that I would like to say here is that the health workers, the exposure was at the beginning of this particular outbreak when we did not know what we were dealing with. And we must really applaud our health workers for being at their point of work. They do what they're supposed to do, despite these risks that they are exposed to. Health workers passing away as a result of exposure to Ebola virus disease does not mean that the outbreak is getting out of hand. What it does mean, however, is that the case fatality rate for this particular virus is still very high because we don't have definitive treatment for it. And therefore, our health workers must be provided with the right tools to be able to protect themselves effectively when they're looking after either suspected or confirmed cases. We send out our deep condolences and wish the families really peace during this time. And we also continue to support the government of Uganda to ensure that the health workers are being given the right protection as they continue to work. But I would like Merawi to give us a little bit more detail with the situation with health workers, how many are exposed, and what we are doing towards addressing the protection of the health workers. Merawi?
Thank you, Dr. Ahmed. Thank you, Judith, for that valuable question. I think just to give you some context, at the beginning of any such outbreak, it is very common to face because the Ebola sign symptom is like any other acute febrile illness, like the malaria, meningitis, and so on. So because of that, health workers are usually exposed until we sort that out and catch it and diagnose it very well. Then all the care and especially infection prevention control measures are put in place. So to give you the context, in general, we have around 10 infected healthcare workers now, and of this, 4 has passed away. And we have noticed that the infection prevention and control measures that need to be observed by all healthcare workers are some challenges there. at the beginning, we gave some high-level training as Africa CDC on infection prevention and control, because that is another vulnerability that we have in our system. So we gave that, but we are going to continue strengthening that space. And just to give you some insight, we have a cargo of PPEs, personal protective equipment, that we are stockpiling that will be shipped next week. This will also give them some leverage to change frequently whatever they have been using in that health facility. I think scarcity also makes them more vulnerable. We want to avoid that by pushing more equipment and supplies towards that, and including the training. That is what I can say for now, but we will give you more update on that. Thank you really very much.
Thank you. Thank you. I think Paul is ready for us now. Paul, please go ahead.
Yes, thank you very much. I have a couple of questions. The first question has to do with clarification on an update regarding testing kits that was announced today. Is it like we now have testing kits, not just PCR, for the Sudan virus? If that is the case, I want to know if you can give us any background information on how that came around, considering we were told this wasn't available in the past. Then the second question I have is regarding when you were giving the different reports on the various outbreaks, there seems to be a wide gap across all these outbreaks between the number of suspected cases and confirmed cases. So which means even for conditions like cholera, we are only having very few percentage of the suspected cases have been tested, confirmed. So I want to know why Africa continues to still have these wide gaps in the ratio of suspected cases and confirmed cases. And my last question is on monkeypox. Still now, we do not have a monkeypox vaccine on the continent. Do you think the continent still needs to prioritize seeking this vaccine? Thank you very much.
Thank you. Thank you very much, Paul. And on the testing kits that have been announced today, we have procured actually 20,000 test kits that are going to be used in Uganda and the neighboring countries in terms of preparedness to ensure that we have a very short turnaround time whenever there is a suspected case. There is no difference from what we discussed last week, the week before, Paul. Rapid test kits is what is not available for the Sudan strain, rapid test kits. What is available are test kits that we use, the usual PCR platforms. And these are the ones that we've procured and are going to be made available within next week to Uganda and the neighboring countries. So we still don't have rapid test kits for the Sudan strain of the Ebola virus. For the gap, it is essentially the challenge of having laboratory capacity to be able to make confirmations for a case. And the challenges are at different levels. First is sample collection. Has a sample been collected? Can it be collected and delivered to the laboratory? Many times you find that cholera is, for example, cholera or many of the other diseases as well, they're happening in a context where the health system is not at its optimum capacity. Therefore, laboratory testing becomes a challenge. Transporting samples from one place to another is another challenge because you need to package it properly. You need to transport it properly. That way, when it reaches on the other side, it can be able to be used in a laboratory setup. That transport mechanism is a challenge, and we continue to try and strengthen that. The last challenge that I would share with you today, why we have this large gap, is the sheer lack of actual facility, not just the test kit, not just the samples, not just the collection, but also the facility. Do you have a facility that can be able to do laboratory diagnosis? And if you have the facility, then you have to start checking, do we have the reagents? Do we have the rapid kits? to be able to do that diagnosis. So it is a challenge, Paul, of resources, something that we have learned painfully during this pandemic, that we need to build up that capacity, and we are supporting the continent to build that capacity as quickly as possible. Monkeypox. Monkeypox vaccines are still not available on the continent. We have not given up. We will continue to look for those vaccines until we get them, because we know that as soon as we control one outbreak, another one pops up. And we want to be better prepared for the next one that may come, even as we treat the current one with the urgency that it needs. We are quite ourselves disappointed that we still don't have monkeypox vaccines here in Africa in use, but we feel that we are almost there now. Looking at the discussion that we are having with the various institutions, we feel that we are almost there, and we should be able to get some doses for our frontline health workers, as well as the highest risk communities to be able to do this. So we'll not give up on it. We will not give up on doing the public engagement that we do. We will not give up on countermeasures being used at the community level. We will not give up working to build our own capacity so that we can be able to manufacture what we need here on the continent. It's a journey. It has started, and it will be completed in a way that provides security to the African continent. Thank you.
Thank you very much, Dr. Merawi. Do you have any additional point?
All right, thank you very much. It is well said. I think regarding to the Sudan virus test kits, it is there is a test, but it is the RT-PCR based, and which is very difficult to decentralize at the district level, at the peripheral level. That is the only issue that we are facing, and we want to really mitigate that by pushing more reagents to the system. So right now, to give you an example, the Uganda Ministry of Health has set up one RT-PCR system in the affected district, and that has really improved the turnaround time to be less than 6 hours. So that was a really very good improvement that we saw. So I think the other one is the wide gap between suspect and confirm is because of resources. It was said very well. And that resource, because of that, we have developed a strategy for different diseases. Like for cholera, if we have this thing, because we can't do every test, where we usually do test at the beginning to confirm the disease, then at the peak of the outbreak to see the trend, if there is any change in any of those pathogens, and finally to monitor the pattern down the course of the outbreak. This is because of the resource limitation, and this gap will continue until we feel that resource limitations. Thank you very much.
All right. Last question from Judith Akolo, and she says, my follow-up question on COVID-19 is what could have resulted in the spike in COVID-19 infections in Somalia? Does Somalia have the capacity to contain the spiraling numbers of infections and deaths?
Thank you, Judith. What causes a spike, a wave to be experienced in a community is really the ease with which the virus can be able to get from person to person. And this essentially means if you drop your mask wearing when you are gathered with people, you expose yourself. If you're not vaccinated, then you're more likely to become very ill and therefore resulting in death. If information is not constantly going out to the population regarding what they need to do in situations of risk, then again, you get exposure. If you're not testing enough to be able to see and know the trends and the patterns, indeed the burden of the infection, then you are also much more exposed. So all these are challenges that have contributed to the spike that we are seeing in Somalia. Indeed, that can happen in any other country that has a similar public health situation of low vaccination and then no public health measures being put in place. In terms of capacity, no country really has adequate capacity for handling a certain surge in numbers of an infective virus like COVID. And all countries globally have struggled. As we speak right now, we are working with Somalia to see how we can be able to strengthen their capacity locally and arrest this particular spike that has come now. And we are utilizing also the opportunity to engage with the public so that they can be able to get vaccinations as quickly as possible, even as we work with our health workers to ensure they have all the tools that they need. These spikes will be expected if we drop our public health measures, if we do not provide adequate information to the public, if we do not have enough population vaccinated against COVID. Thank you.
Thank you very much. Paul, is that an old hand or is it a new one? All right, Paul is muted, so I think that that is an old hand that he forgot to put down. All right, thank you very much. I think now we have come to the time when we close, but before we do that, we then want that usual roundup of the main points, the key points that you would like to take for the journalists to take away from the briefing today. So I come back to you, Dr. Ogwell.
Thank you. Thank you very much, Wayne, and thank you to all the journalists who have joined us today. Three messages that I have for you today. In relation to COVID, number one is vaccination works and protects. It will help countries to avoid spikes, especially when we see the numbers of deaths going up. So vaccination for COVID-19 works, and we are encouraging these mass vaccination campaigns to be well spread so that we can have more and more people getting vaccinated against COVID. Second message I have today is that on Ebola virus disease, it is a risk. It is a risk so long as it has not been brought under control. It is a risk, particularly the Sudan strain where we do not have a vaccine. We therefore need a regional approach to ensure that all our public health assets within the region are geared towards addressing the Ebola virus disease outbreak, Sudan strain in Uganda. And that is why we are calling together the ministers of health next week so that we can be able to agree on a roadmap on how to do a regional approach to this particular outbreak. That way we'll reduce the risks and we can then be able to contain it even faster. Third message is monkeypox is still here with us in Africa. We need, as a continent, vaccines. And we know those vaccines exist. Therefore, we call upon those who have those vaccines, rather than stockpile them elsewhere in the world, they should be allowing them to be put to use here in Africa so that we can be able to control the monkeypox outbreak in the multiple countries here on the continent. And I repeat, I invite you to engage with us and participate in the public sessions of the October 12th meeting, which we'll be holding in Entebbe in Uganda. We will try and set up a virtual link as well, so that you can be able to see, hear, and participate in that particular high-level emergency meeting. Thank you very much.
Thank you very much, Ahmed, for the very detailed information that you keep providing to the media to help in terms of spreading the word on the various pandemics that we have on the continent. Let me also thank Dr. Merawi, who is the head of emergency preparedness and response at the Africa CDC, and he came in to give some details, a lot of details on the Ebola virus disease outbreak that we are currently experiencing. Thank you also to you, our fellow communicators, the journalists, the content creators who have joined us today, and thank you to the crew that is behind the scenes from the African Union and the Africa CDC, making sure that we connect, but also making sure that we are on as many platforms as possible so that this information has a better chance to get to as many African people as possible. All right, that's it for today. Let us meet again next week on Thursday at the same time. Bye-bye for now.
Mm.